Okay, let's unpack this. Imagine a situation, right, where a community faces this really serious health threat. And rapid, decisive action is just absolutely critical. That's pretty much exactly what we're diving into today. We're taking a deep dive into these new revised guidelines for Nipah virus infection, specifically a government order from Kerala, India. It's dated July 5th, 2025.
Yeah, and what's fascinating here really is how these guidelines adapt so quickly when new information comes in. Our mission today essentially is to pull out the most critical insights from this official document. We want to help you understand how public health authorities actually respond during outbreaks,
Okay.
especially when it comes to things like post-exposure prophylaxis, quarantine, and, testing for contacts.
Right. And this isn't just theory we're talking about. These are the actual orders, the ones issued by the government of Kerala, prompted directly by recent cases there. So here's where it gets really interesting. Why revise them now? What was the trigger?
Well, the previous guidelines, they were from back in September 2023. And they covered the basics, the epidemiology, burden, transmission, diagnosis, management, the whole picture. But the catalyst for this specific revision, it was, and I'm quoting here, recent reports of Nipah virus cases in Palakkad and Malappuram districts of Kerala.
Oh, huh.
So the aim was clearly stated, effective disease control and management. It meant updating their approach based on what was happening right then.
And it really carries weight, doesn't it? I mean, you look at who issued it, Dr. Raja Namdev Kobrigade, an IAS officer, additional chief secretary, and then who it went to all the key health officials, state mission director for the National Health Mission, directors of health services, medical education, district medical officers.
Exactly. It shows this wasn't just a memo. It was a directive meant for immediate statewide implementation. Serious stuff.
Okay, so to really get how these guidelines work in practice, we need to understand how they sort contacts by risk. That seems fundamental.
Absolutely fundamental. Everything else sort of hinges on that. The document lays out very clear categories. First, you have the highest risk category. This means any contact with body fluids, so blood, urine, saliva, that sort of thing, from a confirmed case if you weren't using proper PPE.
Right.
So no gown, no gloves, no well-fitted AAA or N95 mask, no face shield.
Okay, direct exposure without protection.
Right. And it also includes anyone doing certain medical procedures on a confirmed case without the right gear. We're talking about things like intubation or BAL procedures, nebulization, even open suctioning. If they did that without an N95 mask and face shield, they're in this highest risk group.
Got it. Then there's the next level down, the high risk category.
Yes, the high-risk category. This covers a couple of scenarios. One is spending significant time close to a confirmed case. The definition is pretty specific. Within 6 feet or in a closed space for 6 hours or more. And importantly, without wearing a proper triple layer or N95 mask.
6 hours is quite specific.
It is. It gives a clear benchmark. The other high-risk scenario is any contact with body fluids from a probable case. So, someone who was suspected of having Nipah and died, but they weren't confirmed by a lab test before passing away.
Okay, so highest is direct fluid contact unprotected, or specific procedures unprotected. High is prolonged close contact unprotected, or fluid contact with a probable case. What about low risk?
Right, the low-risk category basically covers everything else. Things like just touching intact skin of a confirmed case,
Yeah.
or contact with their clothes, their bedding, other items they used. It also includes being in close proximity or a closed space, but for less than 6 hours. Again, without a mask.
It's impressive how detailed these are. It really tries to leave little room for ambiguity.
Exactly. It moves away from just general advice to very specific risk stratification, which is crucial for what comes next.
Right, so once you know the risk level, what about prevention? Post-exposure prophylaxis, or PEP, what do the guidelines say there?
Okay, so this is where it gets quite specific with treatments. For that highest risk group, the recommendation is Remdesivir. That's 200 milligrams as a loading dose intravenously, then 100 milligrams of EV once a day for 12 days. And this has to be done in a hospital so they can be monitored closely.
Okay, then for high risk.
For the high-risk category, it's a different drug, Favipiravir. The dose is 1,800 milligrams twice a day on the first day, then it drops to 800 milligrams twice a day for the next 13 days. This one is oral, not IV.
And low risk.
For low-risk contacts, the guidelines are clear. No need for chemoprophylaxis. No drugs needed just based on that level of contact.
Now, this is a key point for me. Using Remdesivir and Favipiravir as prophylaxis, as prevention, what's the actual evidence for using them that way?
That's a really critical question. And what's quite striking, actually, is that the document itself addresses this head-on. It explicitly states, and again I'll quote, "There is not enough scientific evidence to support the use of either. Remdesivir Favipiravir as PPP.
Wow, okay, so they acknowledge the evidence gap right there in the order.
They do. It's quite transparent. And because of that lack of definitive evidence for this specific use, they mandate that informed consent must be obtained before starting these drugs for chemoprophylaxis. People have to understand the situation.
Makes sense. What about monitoring for people who do get the PEP?
Yes, there's strict monitoring involved. Baseline tests are required for everyone getting either drug. That includes a hemogram checking blood counts and liver and kidney function tests, your LFTs and RFTs. Those tests are then repeated after 7 days or sooner if the person develops any symptoms. And for remdesivir specifically, because it can potentially affect the heart, they also require a baseline ECG, to check heart rhythm, and then they reassess something called the QT interval after 7 days.
So, given the acknowledged lack of strong evidence, why use them at all? What's the rationale provided?
The document justifies it based on, quote, our prior experience with these drugs as PP. Essentially, they're saying that based on how these drugs were used previously in similar situations in Kerala, the risk versus benefit analysis leans towards giving them to people with highest or high-risk exposure. It's a pragmatic decision, weighing the potential, even if unproven benefit, against the risk of a deadly disease.
Right. A tough call made under pressure, relying on past experience more than definitive trial data for this specific use.
Exactly. It highlights the kind of real-world decision-making that happens in public health emergencies.
Okay, so risk assessed, maybe PP administered. What happens next? How are these contacts followed up? What about quarantine?
Right. The follow-up is also clearly laid out based on risk. For those highest and high-risk contacts, if they don't have symptoms, they need to undergo home quarantine.
Yeah.
And it's not just passive quarantine. There's active follow-up.
Yeah.
Health workers check in via phone twice a day, specifically asking about fever. This goes on for 21 days from their last possible exposure.
And if they do develop a fever during that time?
Then it's immediate admission into a designated isolation room in a hospital. No waiting around.
Okay. And how does that differ for the low-risk contacts?
For low-risk contacts, if they're asymptomatic, they don't actually need to quarantine.
No quarantine, okay.
No formal quarantine. But crucially, a detailed aligned list of all these low-risk contacts must be kept, and they still need monitoring. Same procedure. Check for symptoms twice a day via phone call for 21 days. If a low-risk contact does develop symptoms, then the protocol kicks in. They need to be hospitalized, isolated, and definitely tested for Nipah.
That makes sense. Maintain vigilance even without full quarantine. Is testing required for everyone at the end of the 21 days?
That's another interesting and practical point in the guidelines. For asymptomatic contacts, regardless of risk level, it seems testing for Nipah is not required just to release them from monitoring or quarantine after the 21 days are up.
So if you stay symptom-free for 21 days, you're considered clear without needing a final negative test?
That seems to be the implication for ending the monitoring period. It provides a clear endpoint, avoids potentially unnecessary testing on well individuals.
Okay. So stepping back and looking at the whole picture, what does this tell us?
Well, I think if you connect the dots, these revised guidelines really show how dynamic public health responses have to be. They're adapting almost in real time to an emergent threat. And they're balancing that urgency, the need to act fast, with the reality of sometimes limited scientific evidence for specific interventions like PEP. They're leaning on practical, on-the-ground experience to make tough calls and protect the community.
Yeah, it's a fascinating look under the hood. So breaking this down, you've really gotten a clear picture of how authorities are defining risk quite granularly, how they're using these proactive measures like the specific drugs for PEP, even with caveats, and then managing that crucial follow-up with quarantine, monitoring, and testing protocols, all directly shaped by what was happening in Kerala.
Precisely. It's applied public health in action.
It really makes you think, doesn't it? These guidelines, they make very specific, very real-world choices about risk, about treatment, about liberty through quarantine, often in situations where the science isn't fully settled. So maybe the thought to leave you with is this. What does this constant tightrope walk tell you? This tension between the immediate pressing need to protect public health right now and the scientific understanding of a disease, which is, always evolving.